Hi, Professor.
Hello.
Hi, Professor. How are you?
Good. How was you had pharmacology before this, right?
Yep.
Yes, we did. It was good. Went
Yeah.
well.
Who's your pharmacology instructor?
Dr. Atik or Dr. What was his last name?
Okay, we're missing 3 people. Let's get started. Please open up your syllabus. Let's discuss the syllabus first. After that, we will start class. We'll see where we get tonight, and then at 10:20 p.m. you'll take your dosage calculation quiz, the first of 3 tonight. It will be taken through Jupyter, Juno, Pods. You've already used that last semester, so it'll be the same tonight.
Professor,
Yes, Mom.
when we take that, do you want us to be videoing our screen, or do we have to? Can we not show it?
No, we will still do the Zoom. So
Yeah.
need a second device, yeah, for me to see
Okay.
your screen.
All right.
I sent you the syllabus, right?
Yes.
Yeah.
Yes, you did.
Okay. I couldn't find mine. All right, let's begin. Welcome to third semester. This is a large course. This is 8 credits. It's technically 2 courses in one. There's no other course like this in at least St. Paul's or in any other school. I've never seen med-surg combined with pediatrics. How it got to this point is a long story. So it's basically 2 courses in one. There is a move to separate it, but it hasn't been approved by the state yet. So we still are on this combined course until then. To pass the course, you have to pass. You don't have to pass each component. Meaning, if you fail med-surg, pass peds, your grade still gets to a 78%, you still pass the course, right? So there's no requirement that you'll pass all exams for both, okay? So it's one course. You're still using the 9th edition of IGI, so that's what you'll graduate with. So we'll stay with the 9th edition. 10th edition is coming in July, so that will be the next cohort, the 2 cohorts below you. And for peds, they are using, have you had your peds class already yesterday?
Yes.
Yes.
Yeah.
Okay.
Professor,
Yes, boss?
if we have the 8th edition, is it okay, or do we have to get the 9th?
The 9th edition is what I'll be using. There are not a lot, but there are new information in the 9th edition that has significantly changed from the 8th.
Oh, okay, then I'll have to get it.
Page numbers are also different. Chapters may be slightly different.
Okay, thank you.
But it's a good investment. You know, you invest in your future.
Yes.
Maybe, yeah, plus you can't do manicure nowadays anyway. You're stuck here. So yeah, invest in your textbooks, okay?
If we're getting the textbooks from the school, do you have a code to give us, or should I email someone about that?
If you need an ebook, just let me know. They put the codes with us. So how it will work is you email just one instructor. Okay, do not email multiple instructors. Email one instructor and then ask for the code, and then that instructor will provide you with one. Once it's redeemed, be careful with it because it's good as cash. So if you lose it, somebody picks it up, redeems it, there's no way to track it, apparently.
Okay, and that's for each textbook, right?
Yeah, if you don't have your
Okay, I'll email you after class.
Okay, all right. So how are you graded? We have 2 courses, 2 components. Like I said, there's a med-surg and a peds course. There are 4 unit exams. Each one would come out as 11.25%. One final exam, 25. There is a plan to give a specialty exam this semester. How that will be done and what product will be used, I have no idea. But that's what we were told, that there is a plan to give a specialty, so that's why it's still in your syllabus. There are 5 quizzes total, 3 quizzes for med-surg, 2 quizzes for pediatrics, so that's 1% each. These 2 focus competency development online quizzes are your tickets to test for HESI. I believe you've taken one also last semester for fundamentals. So it's the same one. This will be due around before week 13, before your scheduled specialty exam. There are 4 case studies. Each would come out to be 2.5%. 2 for peds, 2 for med-surg. Mine is already up. I put it up on the course ID that you guys are using, which should be this course ID. If you're not in here, please put yourselves in here. Can you see the course ID?
No, we don't see it.
I don't see anything.
No, sir.
How you still see the syllabus?
Yeah.
Yes.
Okay. Okay, here it is. So most of you are already here. I breezed through it. So this is 10151 underscore S Tolentino 14 underscore 10.
And that's for just the case studies?
Yes, sir. The case study and also the 2 1% tickets to test. They should also be in here.
Okay.
So to access it, so you go in, course home. It's slightly different now. They open in a separate browser, unlike before where it's in the same page. Now this thing opens in a separate browser. And mine is these two. So you see hypertension. This one is due by June 23rd. Coronary artery disease, July 14. You can do them now or wait till later. They are set to for 1 attempt only. There is unlimited time, so you have all the time in the world. It's basically open book. That's why it's only 1 attempt. So that takes care of that. Miss Professor Buckner, who is your PEDS instructor, will put up her case studies as well as the 2 tickets to test. Okay, so I'll leave that to her. Saunders. So you...
I'm sorry, Professor. I didn't get a chance to see how you got to the assignments. Is it the same way that we would get to it normally through Evolve?
Yes, the only thing different is if you click on the case studies, it opens in a new window.
You broke up. I can't hear you.
The only thing different is the case studies now, the browser opens up in a new window.
Can you repeat that? Because I got kicked off for a second.
It just opens up in a new browser, in a new window. That's it.
Okay.
But it's the same thing. All right, for Saunders, which is worth 3%, there are 250 total here. So how this works is there are 7 on the calendar. I'll show you here. On the weekly calendar, first one is due week 3 for med-surg, so that's 1. Here's number 2, week 6. Number 3, week 8. Number 4, week 9. 5, week 11. 6, week 12. And 7, week 14. So that's 7 for med-surg, and I believe there should be 3 on pediatrics. They are due when they're due. They are not recorded if they're submitted late. Now, how do you give it to me? So you go to your case study course. I mean your Saunders, sorry. So whichever Saunders course you're using, launch it. You see my screen?
Yeah.
Yes.
Okay, so on your Saunders homepage, after making one, right? So we only require 25. Of course, you can do more. Each 25 is one set. So if you do 50, that's 2 sets. So how you send it to me is click on the one you intend to submit. I mean, email to me. By submission, I mean by when you did it. Okay, so when you submit the test, when you completed the test, that's what we call submission. So if it was submitted on due date is always where it's put in the week. So when it says week 3, your week 3 is technically May 19. So you should have completed one set of Saunders questions by May 19 before midnight, because that is your week 3. Okay, so let's say you open up one. So this is 50 items, so this counts as 2. Now, let's say you score like this, really bad, it's 2%. No big deal. You do remediation. So you click review and do your review. You can't see it, but on the instructor's side, we can see the time, remediation time you did. We have an option to look at the total time, so we can see how much time you spent on it. So let's say 50 items and you only scored 2%. That means you only got, well, that's not even,
You only got one wrong, right?
right. So that would be 49 items that you need to review. Now we require 1 minute per question. So if I see 49 minutes there of review, then that means you completed the remediation. You don't get the 2%. You will get the whole 100 for that week. Okay, so no questions asked. If there's complete remediation time, then you get 100 for that week. No questions asked. So please email it to me. So click on it, click here, email results. And I already sent you my email address in the email through Jupyter. So just email. Yes.
So if we got like a 92, do you want us to still remediate those the ones we got wrong? Like for every time we don't get 100?
You don't need to do anything. It's a free country, really. So if you don't remediate, that means you want your score to be
To reflect whatever.
recorded, right? So it's up to you. You don't want 100. You want just 50 or this one 2%. You're the boss. I'll put 2% there. Okay, I get what you want.
Thank you.
Professor, I have a question. So when you're inputting the grades for the questions, do you just input if we did it, or you input the actual grade that we got?
Again, you have 2 options here. You either remediate and get 100% for your score for that Saunders, or not remediate and tell me to just post the score that you got for that assessment.
Got it. Thank you.
Yeah, so let's say this one 2%, and you don't want 100. I want 2%. So you just email this, and then when I check that there's no remediation, that's what I'll post for your score for that week. Okay, so just email results, and please, I try to respond within 48 hours. I mean, I try. So far, I'm able to. The ones I received as of yesterday, my inbox so far is clear. I have no emails to return, but it may not look like that as our all classes meet, because I have a total of 69 plus 28, that's 97 students total. So that's about possibly 97 emails a week. So please be patient, okay? Any question on Saunders?
Professor, you said you require 7 from this class and 3 from peds?
Yes, 7 sets of 25 item practice tests. Just follow the course calendar about when they're due. Okay, so I do send you an acknowledgement that I received it, and I give you how many you've sent me total so far. So again, I'm expecting 7. So the email will say I received 1 out of 7, 2 out of 7, and so on. All right, as I receive them. Questions on Saunders? Very good. Alrighty, so let's continue with the syllabus. All right, so that completes the 100%. As usual, the St. Paul's grading is weird. You need to get 78% out of these first, out of your unit exams, final exam, specialty, and the quizzes. Once that reaches 78, then all the other points get added. Otherwise, they will all be entered as 0, which will drop your final course grade further. We are now in a virtual environment, so clinical part is virtual. So you guys are using Swift River vClinical. Clinicals will continue to be asynchronous this week, meaning you meet your instructor one day for post-conference in one day, or the post-conference could be another day, depending on your arrangement with your instructor. And you do that for X number of weeks and you're complete. There is no more simulation because it's not possible to implement. I don't know how, which activities on vClinical. It'll still be Swift River for your skills lab. I just don't know which activities they'll use. This is your outline. Head surge only covers these areas here. There is one thing missing. I just noticed it, which is the surgical, fluid and electrolytes, which is part of post-op care. And that's the only thing missing here. All right. So you have your weekly calendar. You're on a Tuesday, so there's no holiday impacting your schedule. There is, you end on August 14, I believe. No, August 11, sorry. 14 is a Friday. So your last day is August 11. That's your final exam. And it's going fast. In fact, you only have 14 weeks left. Today's almost over. So please do your practice exams. I'll follow up with Kaplan about your access. Please use the Kaplan channel. Once you have access one of these weeks, I'll introduce you to it. Just want to make sure first that the rep has all your emails so she can make sure that you all have access. Okay.
Professor, I have a question. So we're using 2 textbooks for this class, right?
2 required textbooks, yes. Ignatavicius MedSurg, and I believe it's Wong for pediatrics.
Yeah, the one I'm looking at now that says the basics 2016. It's on the weekly schedule. Yeah, like.
All right, this thing is a ebook. No problem, it's free. You download that from the Kaplan website, which as soon as you get access to it, it's right on the upper right corner of your homepage. It will say download your ebooks here. So it's a PDF document. Just download it. What it is a outline format. It's designed for NCLEX content review. Just a warning, that's all it is though. It's a content review. It does not replace textbook content. It will only have very short information per topic. Okay, again, it's designed for NCLEX review, which you can also use when you study. You use the outline to cover whether or not you know the topic based on each bullet.
Okay. Yeah, I'm just not sure how to access that just yet.
Okay. Yeah, it's a free PDF. Don't worry. Like I said, I already have notes here to email Kaplan for your access.
Perfect. Thank you so much.
And we'll go from there. Any other question for the syllabus?
I have a question about the Saunders.
Go ahead.
I realized that I had purchased the book on my own and I never used the code, so I just entered it, but it's not allowing me to enter the like I'm on Evolve now and it's saying enter your instructor's course ID. It's not allowing me. Is it because I purchased the book on my own?
No, it's okay. I'll give you a course ID. It's just looking for a course ID. You can use anyone's course ID.
Okay.
Just give me a minute. And you can use this one.
Hold on. Oh my God. Okay, I'm just going to take a picture. Hold on. Okay, I got it. Thank you.
You're welcome. That'll be $20, okay? I'll just collect it later. I'm not kidding. Any questions, future nurses, on the syllabus?
Wait, Professor, that was a different course ID from the first one you showed us.
Oh yeah, that one she asked for was the Saunders. The one we took earlier was for the HESI RN case study course, where your case studies and your ticket to test will be.
Okay.
Yeah, because it's a different product, it's a different book, so they have different course IDs. Anything else? Alrighty, so let's begin. Recording. Yes, we are recording. All right. All right, we will begin with chapter 14. Can you see? No, you can't see it. All right, now you can. All right, we will not be discussing the entire chapter 15 because on the NCLEX blueprint, it made no mention about intraoperative care. The reason probably is you're not usually expected to work in the OR, or I'm not saying you can't. You can, but you're not expected to. But every fresh graduate during the first 6 months to 12 months of your practice is expected to know how to care for a patient before and especially after surgery. So that's why we will focus only on chapter 14 and 16. However, the same NCLEX blueprint also says that emergency procedures are expected, meaning you're expected to respond to emergency situations. Now, you can't respond if you don't know what the emergency looks like. So there is one emergency in chapter 15 called Malignant Hyperthermia. So that is the only topic we are discussing in it, just because there's an emergency situation mentioned there. So it'll be 14, a tiny bit of 15, and then chapter 16. After that, we will go to 17, which is immunity. Then from there, we'll go backwards back to 11, 12, and 13. So your first exam will cover, therefore, chapters 11 through 17. Is that clear?
Yes.
Okay. All right, let's get started. So 14 and 16 covers the whole surgical experience. Surgery is a money-making business for any hospital. Medical floors, especially those with common illnesses involving elderly, are not very profitable. Hospitals, in fact, private hospitals are getting rid of their medical floors because they're losing money in it. The reason is people fall, that's not paid anymore. They fall and break their hip because the fall occurred in the hospital, so that's not a very good situation for the shareholders of the hospital. Okay, so as highlighted here, cost reduction is a driving force for managing a surgical patient. So even though you're supposed to make money from a surgery, if the patient develops complications after surgery or even before surgery, meaning these are otherwise preventable situations, but the hospital and the nurses failed to prevent those complications, then the hospital will have to foot the bill in caring for the patient due to that complication. So the shorter the patient stay, so which is the next statement now. So the shorter the patient stay, the better money they make. So you're aware of ambulatory surgical sites. We have same-day surgeries. We have the hospital for special surgeries or special procedures. Okay, there are centers that focus only on, let's say, urological surgeries, eye surgeries. Those do not commonly require inpatient stay. So as a nurse preparing a patient for surgery, you are expected to be aware of a core measure called Surgical Care Improvement Project. Core measures are developed by the Joint Commission, the purpose of which is to standardize the delivery of care, meaning wherever the surgical setting is, whether it's inpatient, outpatient, or same-day surgery, that is, the same care is given. And if you expect to have the Joint Commission seal on your facility, you have to implement these core measures. So they're listed right here. Core measures, by the way, are not exclusive to surgery. Core measures are set by the Joint Commission for all commonly occurring disorders. There's a core measure for stroke, for pneumonia, for COPD, diabetes, heart failure. Name any chronic or acute condition, there's a core measure for that. The purpose again is to standardize the delivery of care, regardless of who the patient is, where the hospital is. Core measures are imposed by the Joint Commission. Of course, the hospital, if they don't expect or they don't want Joint Commission accreditation, then they don't have to follow it. But those who do have to. So Table 14-1 is the Surgical Care Improvement Project. It's a set of about 10, let's count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yeah, 10 core measures. Let's discuss these briefly. So every surgical patient must receive all of these if it applies to them, meaning before the first incision is made, the patient has to receive antibiotic. This is called prophylactic antibiotic. So it doesn't mean the patient has an infection. This is to prevent infection. The most commonly prescribed antibiotic is, of course, penicillin. They use Ancef, which is a penicillin. They give it 1 hour before the first surgical incision. There are multiple surgical incisions. The first one is, of course, to break the skin, and then they change the scalpel. Another scalpel will be used to make a internal incision. For obvious reasons, we cannot sterilize the skin. So that first scalpel is, of course, already contaminated once we make the first skin incision. Next is prophylactic antibiotic selection. Of course, if the patient has a allergy to penicillin, then they'll use another one. They can use either Cipro or another choice by the doctor. Cipro is a fluoroquinolone, which also works for surgical patients. Okay. So sorry, I forgot to take attendance. So we are missing 2 people. No, 1 person. Sorry for the pause. All right, for cardiac surgeries and only for cardiac surgeries, they specify that this, of course, applies to diabetics. Before cardiac surgeries are cardiac catheterization, coronary artery bypass surgeries, valve replacements, anything involving manipulation of the heart. They, on the surgical day, the sugar must be under 200 by 6 a.m. of the surgical day. The purpose of which is they're concerned about healing and perfusion during the surgery. If your sugar is really high during surgery, that means blood flow is very sluggish, and therefore that will be unsafe. Okay, the patient not only might suffer complications during, but most especially after. Concern is surgical wound healing. Next is the hair removal. Hair removal doesn't have to be shaving. Okay, we only clip the hair. So let's say you have a really hairy patient. We do not use razors. We use either electric clippers or chemical depilatories. They use creams in order to remove the hair, but I've never seen them use creams. They use the electric clippers. Catheters. Not all surgeries will require a urinary catheter, but long surgeries do. If the surgery is not expected to last more than 2 hours, they don't bother with putting in a catheter because it's not needed. Plus, again, the whole purpose of this is the development of catheter-associated urinary tract infection. So a catheter must be out of the patient, must be removed by post-op day 2. Post-op day 0 is the day of surgery. So if I have surgery tonight, post-op day 1 will begin tomorrow. Although the maximum is post-op day 2, that means 48 hours, there's nothing stopping you from removing it before 48 hours. So the sooner you remove it, the better the patient outcome will be. This will be a common discussion if we ever get back to the hospital. Whenever you attend the morning powwow at the nurse's station, you'll see them constantly asking, who has catheters, who has central lines? Okay, because these two invasive catheters are high risk for infection. So they do not want any UTIs, no catheter-related infections on any floor. Okay, that doesn't look good for the Press-Ganey surveys. For those of you who've had surgery, I'm sure nobody will say that the OR is warm. They keep the temperature down, freezing actually, not only for retarding bacterial growth, but also to keep everything, because most of our equipment are sensitive to heat. So therefore the patient is exposed to hypothermia during surgery. The patient, of course, is naked and they're laying down a cold steel, stainless steel operating table. So they are exposed to hypothermia. So you should monitor that during surgery, and then you continue after surgery. Beta blockers. Beta blockers are given for a specific reason. Usually these are for heart disease. Beta blockers are not designed for hypertension. Okay, it just so happens that it's also used for hypertension, but by design it's a beta blocker. So therefore it's designed to prevent a failing heart, an injured heart, from beating normally. We don't want it beating between 60 to 100. We want it to beat between 50 and 60. So there's a reason why the patient was put on beta blockers. So this should not be withheld on the surgical day, because heart rate will be expected to rise when you experience surgery. So the moment they tell you that you're having surgery, you're already anxious. Plus your body reacts the same way when it undergoes the first incision. That will automatically trigger the sympathetic nervous system response, increasing the heart rate. So all of them are harmful to a patient with heart disease. So they must continue to be given. Although the patient's NPO, the day of surgery, in fact, after midnight, the patient's physician or surgeon must be made aware that they have to receive the beta blocker in another form besides PO. DVTs are common before, during, and after surgery. So Dvt prophylaxis is a necessary intervention. Before surgery, we already institute them. We'll discuss the ways by which we institute Dvt prophylaxis when we get to chapter 37, I believe. That would be for the second exam. And finally, you continue the same Dvt prophylaxis within from within 24 hours before surgery to 24 hours after surgery. Now, this is in relation to surgery only, okay? If the patient continues to have the risk for Dvt prophylaxis, of course we continue it, but this 10 core measures are only for surgical care improvement project. Okay, so for surgery purposes, that's why they say that the Dvt prophylaxis must be continued up to 24 hours after surgery. All right, but again, because the patient remains immobile or at least with significant reduced mobility after 24 hours at the end of surgery, then we continue the Dvt prophylaxis, but that one is no longer in relation to skip. Which reminds me, I forgot to talk about the when to stop the antibiotics. Okay, so core measure number 3. That same prophylactic antibiotic that you gave 1 hour before the first incision must be discontinued within 24 hours after the end of surgery. So let's say you had a patient who started a surgery at 6 a.m. That means we had the first antibiotic at 5 a.m., correct? So let's say the surgery ended at 12 noon of the same day. So the antibiotic will continue to be given up to 12 noon the next day. Okay? Any question on that? Okay, very good. So let's continue.
Wait, so they have to take the antibiotic 24 hours after the surgery, after their first?
Yes, 24 hours at the end of surgery. So whenever the surgery end time was, meaning after we close the incision, the antibiotic stops 24 hours after that time. Like I said, the antibiotic is prophylactic. It's usually NSAID, and it's usually given every 8 hours. So, so the patient will at least get 3 doses regardless, right? Because it's 24 hours after. And most surgeries last, I don't know, a couple hours, or if it's a major one, then those are the only ones that really get more than 3 doses. Okay, there'll be a question on this, on the type of surgery, because there are different reasons or purposes for surgery. Table 14-2 tells you the reason, and they give you examples here. So it's self-explanatory. Diagnostic, this is the purpose, and these are examples. Okay, please just read it on your own. I won't discuss that in class. For the surgical approach, almost everything is going toward minimally invasive surgeries now. They discovered that they make more money this way. Of course, they don't advertise it like that, but they say, faster recovery, faster, better patient outcomes, less complications. If you do minimally invasive, meaning the less incisions you make, the faster the patient recovery. And of course, the better money they get. There are risk factors. So we're still in chapter 14. So the setting is for inpatient, the patient obviously is on the medical or surgical floor. You're preparing the patient for surgery. If it's same day, you still do the same. You do this in the holding area, because they're told to check in 1 or 2 hours before surgery, and then you do the checklist. They try not to do the checklist too far ahead, because things might change between when you did the interview to when the patient comes in for surgery. So they try to do this as fast as they can, although they have instructions already as far as the really crucial stuff like being NPO for so many hours, making sure they don't take any drugs that cause or prolong bleeding like aspirin or NSAIDs, for instance. Those are standard, but the pre-op checklist usually is done right before surgery. The patient's history is already done by the surgeon anyway, the moment the patient decided to have surgery during the consultation, so they have that data. So these are some of the common information that a pre-op nurse will have to do. You are the pre-op nurse, okay? The pre-op nurse isn't just working in the OR. You are the pre-op nurse. So if you're preparing a patient for surgery, then this is your job. If you have downtime, which is usually after 11 p.m., or if you're lucky, you have your downtime starts at 9 p.m. if you work on the night shift, this is the time that you do your pre-op checklist because it's really long. It may look short here because this is the textbook, but imagine when you click on medical history, for instance, it will populate a whole list of radio buttons, okay, for you to click. Although they're all check boxes, it's still quite at least 4 or 5 pages long. Computer pages, that is. So these are the information you need. History of tobacco use, alcohol, including marijuana. Reason is this will affect pain management pre and post-op. So knowing that is crucial so that the doctor will know how much dosing of the pain medication and even anesthesia will be used. Herbal medicines like the St. John's wort, garlic, ginseng, ginkgo, which are commonly used by the baby boomers, cause prolonged bleeding. So it would be great to know that. That way we're prepared. Prior surgeries would of course be important, especially if they've had the next bullet, which is if anytime they have a problem with anesthesia, that is a red flag. We'll discuss this more when we get to chapter 15. There is blood loss in surgery. How much will depend on the procedure. Most surgeries will at least have a order to type and screen. They add a cross match if they anticipate, meaning if the surgery commonly requires a transfusion, then they'll do cross matching for 1 or 2 units. But if it's typically not expected, the order they'll write is type and screen only. No need to cross match. But at least we have the type and screen so that if the patient has any unexpected bleeding, then we can simply add the cross matching and the transfusion order. Most elective surgeries have the option to bank their own blood, meaning they can deposit it 3 months at least before their scheduled surgery. That's the safest way to go. That way you don't have to deal with transfusion reactions. This will be suggested by the physician.
Professor,
yes, go ahead.
what would be an example of a surgery that they would put that as an option?
You mean for blood transfusion, autologous?
Yeah.
Major surgeries like heart surgeries or even joint surgeries, because they're expected to be really bloody.
Okay.
Hip surgeries, knee surgeries, they ask them to do that. Some hospitals don't, especially if they do laparoscopic, meaning minimally invasive approaches. Those doctors or surgeons do not ask their patients for autologous blood banking. Okay, there's no need. But there are still some old school surgeons who do that.
Thank you.
All right. And post-op planning is always planned before surgery. We can't just have surgery and then think about it afterwards. Okay, so we have to know what is the plan. After you get surgery, where are you going? Are you going home? Are you going to a rehab facility? All right, of course, we don't have that option in the case of emergency surgeries, but most surgeries are elective, so we have to plan all these things. Table 14-3, this is still part of your pre-op checklist. This one is in relation to overall surgical risk, meaning complications. So if the patient meets any of these listed in table 14-3, then you can prepare. For instance, we already know that if a patient is taking these, that means the patient already has hypertension to begin with, and hypertension is always associated with heart disease. Antidepressants, anticoagulants especially, because if the patient requires anticoagulation, although you can stop it during surgery, you have to continue it right after surgery. Example is, let's say the patient has atrial fibrillation and therefore is at risk for throwing blood clots at any time. So patients like that, they will have to be admitted sooner in the hospital, whereas any other patient can go check themselves in the night before surgery. These patients will have to come in 3 days before surgery because we have to switch them from oral to IV anticoagulation, meaning the risk for which they are given anticoagulation for does not disappear just because you undergo surgery. They remain. So to safely switch them, because oral anticoagulants take time for the drug to leave the body, but meanwhile they need anticoagulation. So what we'll do is switch them to a anticoagulant, IV anticoagulant with a really short half-life. That way, the moment we go to surgery, we can simply stop the anticoagulant infusion 1 to 2 hours before surgery, and then put them in the OR, do the surgery, and then right after surgery, continue the anticoagulation. It's a bit complicated, but that's what we do. So medical history, obviously all these will affect not only surgery, but post-op care. We already mentioned use of these substances, and nutrition, malnutrition that is, including diabetes, will be concerning for not only infection, but also healing. This is for anesthesia. We'll discuss malignant hyperthermia in chapter 15. Cancer, of course, they are immunosuppressed, whether or not they are receiving treatment for it. And the surgical site also. So let's say if you're dealing with thyroid surgeries, for instance, which is on the incisions right in the neck, very close to your airway. In fact, it can injure your trachea. So those will be high risk. Chest surgeries also, or large abdominal surgeries. That's why they always go to the ICU for at least 12 hours or at least overnight before they go back to the surgical floor. And if it's an abdominal surgery, this is always a concern. Ileus, because just like anybody, if you've been beat up, somebody punched you, manhandled you, which is what's happening to the bowels during surgery, you're not going to function. So this patient will have fecal impaction, severe nausea, vomiting after surgery, and of course they're high risk for DVTs because it's hard to get out of bed with a large abdominal incision, especially if the patient is also obese. We'll skip table 14-4. This part now is not a nurse's concern. This part is because we're doing the pre-op checklist. You're expected to see the patient's risk factors and plan accordingly, like notify the physician, for instance, so we can decrease the risk. This one is simply for the anesthesiologist, and we're not nurse anesthetists straight out of graduation, so we have a ways to go before we become anesthetists. 14-1, this is nice to know because most of our patients are elderly. So meaning these changes right here will put the elderly at a disadvantage. For instance, if you look at kidney, for instance, for kidney function, to begin with, the elderly already has decreased renal function, meaning this will be a concern with drug elimination. We will be flooding this patient with drugs, beginning from pain medication to anesthesia to muscle paralyzers if they're getting general anesthesia. So therefore, these drugs can easily accumulate in the body. And of course, the bleeding that happens may cause injury to the kidneys, which is possible. So they need to closely monitor kidney functions all throughout surgery here, and then continues post-op. So the same way for cardiovascular and respiratory, for instance. Okay, so please read on your own. I already discussed this. These are a concern. So let's say the patient is alcoholic. So you may want to put the patient on a withdrawal protocol. Once they get into DTs and they have a fresh surgical incision, that's not a good sight. You'll see a patient thrashing around and your incision bleeding, opening up in some instances. So you have to prepare for these things. So they'll need some benzos to prevent this thing from occurring, because alcohol withdrawal can occur as early as 24 hours. This is more of a concern with emergency surgeries, because usually if it's an elective surgery, the patient already goes into detox before they go to surgery. But if we are faced with an emergency surgery, we had no time to prepare for detox. And so the patient might go into DTs. These explanations, by the way, beginning from here, are the explanation of table 14-3. Okay, so everything here, 14-3, are explained in these paragraphs here, right after this chart. So beginning here, they explain the significance of those pre-op checklists that you have to go through. Okay, meaning assessing for the risk, surgical risk, pre and post-op. With regards to blood donations, you guys are aware about Jehovah's Witness, right? I mean, at least you should be.
Yes.
Yes.
Okay. Depends also on I wasn't aware that there are levels. I mean, there are variations with the practice. Just like for Catholics, for instance, like I'm Catholic, but I can say that I'm not that Catholic, meaning I'm not that, a die-hard Catholic. So apparently it's the same also for Jehovah's Witness, because there are some Jehovah's Witnesses who receive blood transfusion, but it's only their own blood, meaning these are variations already with the practice of the religion. Okay, but you don't assume though that it's like that. We did discuss discharge planning. Again, this should be started before surgery. We have to know what to do with the patient after surgery, because that will just lead to problems with discharge. So the patient may stay unnecessarily long because we didn't prepare for discharge planning. Most of these assessments, by the way, continue into chapter 16. So you'll see when we get to chapter 16, they will sound redundant, okay? Because you'll be reminded, oh, didn't I read that already in chapter 14? Yes, because you continue the same assessment from pre-op into post-op. Here's another chart on the surgical, on the older adult again. This is related to the chart we skimmed through earlier about the physiologic changes related to aging. And here's continuation of the table assessment for the patient's risk for surgery. They continue here. Just because these organs are your compensatory organs, meaning the heart, the lungs, and the kidneys specifically, are the organs that will compensate during and after surgery. So if the patient therefore has problems with them to begin with, then that will affect their tolerance, both of during the surgery and complications that follow post-op. We just need to be ready. I mean, regardless if they have those diseases, they have to undergo surgery. Although for elderly with extensive cardiac history, they will need cardiac clearance, meaning the cardiologist has to sign off whether it's safe to perform surgery on the patient. Those are, of course, exceptions. Neurologic status is included because since you have a risk for developing blood clots before, during, and after surgery, if that blood clot does become an embolus, so it may result in a stroke, which is quite common regardless if it's a minor or major surgery. Okay. I remember 2016, a group of students and I were in Queen's Hospital, and we discovered it. Actually, I shouldn't take credit. It was my student. The student came in. The report said the patient was alert and oriented, walkie-talkie. And it took us time because the patient was on contact precautions. So he had to do PPE. Student went in, did his assessment, came out. And when I asked him, so how'd he go? Student said, he's not responding. He's just staring at me. He wouldn't do anything. He was nonverbal. So it didn't make sense. So I went in with the student, and then fair enough, he was flaccid on the right side. Totally nothing. You bring up his arm, it will drop, no movement at all. So we called the nurse right away. They called rapid response, and the patient had a stroke. And the surgery he underwent was only the placement of a pigtail catheter for his kidney. He was in for hydronephrosis, meaning he had bladder cancer and he can't pee. So they put a drain into his kidney to drain the urine. And it was a minor surgery.
Professor, was that at a nursing home?
No, Queen's Hospital.
Oh yeah, you said that. Sorry. Okay.
All right, nutrition is important for recovery. Okay, so which is for every patient that's sick, whether you had surgery or not. You need high protein, or at least adequate protein, in order for your body to heal. Obesity is already considered malnutrition. Okay, they may look pretty healthy, but you know that the obese patients are not, because of the strain it puts on the heart muscles, and they all are connected together. You can't exercise well, your immune system is weak, and so on. Which is pretty much me nowadays during the lockdown. Labs, these are standard pre-op labs to be drawn. I already mentioned the type and screen. The urinalysis is important for checking to make sure that there is no UTI before surgery. Because if the patient develops UTI, or if it's at least diagnosed post-op, then that means the UTI occurred in the hospital. So we need to establish that it wasn't that, if there is a UTI, that it was present before surgery. CBC, for obvious reasons, we need to know the blood count to compare before and after surgery, blood loss wise. Clotting studies, we need to make sure they don't bleed during the surgery. Electrolyte levels, because especially potassium, because we did place the patient NPO before surgery, and that could continue 8 hours before surgery, and they continue to be NPO afterwards. And remember, potassium, the only way we get it is through food intake. So we anticipate that for electrolyte replacements post-op, because again, the patient, although we can reorder the meals, the patient might not tolerate PO intake yet. Creatinine and BUN, that's obviously for renal function. Again, the kidneys suffer some extent of injury during surgery because of the bleeding. So an automatic response, again, whenever we have stress, which surgery is stressful, is the sympathetic nervous system response. And the renin-angiotensin-aldosterone system, all of which cause peripheral vasoconstriction and resulting in decreased blood flow to the kidneys. So that causes the injury to the kidneys. Okay, so these are our problems. It's mostly hypokalemia, but if the patient now has kidney injury, it may turn into hyperkalemia because 80% of our potassium is excreted by the kidneys. So if they fail, then there's no way for your body to get rid of potassium. I already mentioned potassium, so here's your critical rescue. Imaging are not routinely done. An X-ray, probably if the patient has a history of heart condition or lung condition, then they'll order an X-ray, but otherwise that's not routine. ECGs, though, are routine for a specific age. So here, once you hit 40 to 45, or in some hospitals, they start at 50. Used to be 50, but we're starting earlier now. Because that's when you start having heart conditions, or at least dysrhythmias. So we need to know baseline and compare it with post-op. You can skip 14-3. These are again redundant. This is already implied in the assessment that we did in the previous paragraphs. So this includes the urine, lung function. We did the CBC already, so these are all included. Let's resume. Okay, so now we're in educating the patient now. Consent will follow next. So, explaining to the patient what's expected before, during, and after surgery is done obviously pre-op. We can't really stop the patient from drinking water if they really want to. I mean, there's water in the tap in the bathroom, so they'll drink it if they really want to. The important thing here is your explanation. So don't just, during this education, don't be in a hurry by just saying, don't have anything in my mouth. Okay, you can't drink anything or eat anything. Don't take these pills, right? Don't get out of bed. whatever it is, there has to be a rationale. That way you get the patient's cooperation, because really it's there for their own good, right? So explain it in simple terms, why we're doing certain things, why they have to comply, okay? So it's really for their own good. Once the patient understands, then they'll comply because it's really for their own sake. Plus, you'll just be in trouble anyway, because the surgeon, if let's say this patient ends up drinking water, the surgeon, remember, is expecting to be paid that day. Okay, he's already on the schedule, and he's probably earmarked his, no, I'm just kidding. Any changes here, if this patient, if the surgery doesn't go through because you violated the pre-op preparations, okay, let's say especially the NPO part, patient drank water or ate something, remember we have to do the things all over again, and then that will change the schedule in the OR at the same time. So it becomes there's a ripple effect there. Teaching will be done, well, if you're in a special unit, let's say you're an orthopedic unit, bariatric surgery unit, OBGYN unit, you have standard teachings already. So you have packets available in different languages, you have DVDs, instructional videos to make your job easier. Okay, that's part of your pre-op preparation. And this is your the checklist again. This time this is for preparation for post-op. So you discuss, and this is the checklist on the Epic. We use Epic in city hospitals, so they will be part of your pre-op checklist. So make sure they understand these post-op, that they'll have drains, for instance, they'll have a catheter. The catheter, the urinary catheter, is sometimes put in the OR because they try to lessen the time that it's in there. So they don't put it in pre-op. It's really not necessary. Coughing, turning, and then the proper way to do that, of course, is to splint the incision, especially the patient, if the patient has an abdominal incision. Incentive Spirometer, the same thing, because we use the we can use the abdominal muscles, so that might cause strain on the incision. How to use it and how to use it correctly, okay, and then how often. Sometimes we take this for granted, and it's embarrassing if we see a doctor having to do it, because when the doctor makes rounds, they ask them, have you been using the incentive spirometer? And then the patient says no, and then asks why, and they said, nobody told me what that is. Okay, that's embarrassing, because this is a expected nursing function. It's very simple to teach, and then we don't do it. Because the patient has immobility after, or at least decreased mobility post-op, so we need to do Dvt Precautions. That's where your lower extremity or leg exercises come in. Then you have stockings. Early ambulation is best, but that's what we call aspirational, okay, because most patients have severe pain, and even if you medicate them before ambulating, they will still refuse to get out of bed, but that's your job, okay? You're not there to baby the patient, you're there to prevent complications, so do not baby the patient, okay? So be stern about ambulation, okay? If they say, I don't want to get up, you be firm and say, get your ass out of bed, or at least sit them in a chair, okay? That's better than laying down flat in bed. Pain management, we'll have different issues on that separately. Here is consent. What does consent mean? Thank you for reading, Miss Gentleman here. Joseph.
Yes.
Oh, Joseph is a female?
Yes. Is
Ethan?
Joanna Joseph? Yes, that's me.
Ethan Joseph?
Well, I'm using my son's computer.
Oh, okay. Okay, go ahead. Thank you for volunteering to read this. What does consent imply?
That the patient has sufficient information to understand.
To understand what? So let's read these. What do they really understand when they sign that consent form?
The nature of and reason for surgery. I have to read all of that?
Yes, please.
Okay. The nature of and reason for surgery, who will be performing the surgery and whether others will be present during the procedures, example, students and vendors, all available option and the benefit and risk associated with each option, the risk associated with the surgical procedure and its potential outcome, the risk associated with the use of anesthesia, the risk and benefit and alternatives to the use of blood or blood product during the procedure.
Okay, thank you so much. That's okay. Thank you. But remember, the patient can revoke that consent anytime. Okay, just because they signed it doesn't mean they can take it back. They can't take it back. They can. So these are standards. So this is a generic form. So you see the surgical procedure is blank. So they leave it blank. They just write it down here. What the procedure is the patient's name, and then the surgeon's name will be here. And these are standard statements alluding to these items here, especially the risk part. So here is the standard disclaimer that says here, I understand that anesthesia involves risk in addition to those resulting from the operation itself, including but not limited to dental injury, hoarseness, vocal injury, infection, nerve injury, corneal abrasion, seizures, heart attack, stroke, and even death. So these are standard statements. Okay. And as I already said, the job of doing this, all explanations here, is the surgeons. We take no part in that. So what is our role regarding consent? Thank you for reading, Miss Escobar.
Okay. Sorry. You want me to read the highlighted part?
Yes, please. I'm tired.
The perioperative nurse is not responsible for providing detailed information about the surgical procedure. The nurse's role is to clarify facts that have been presented by the surgeon and dispel myths that the patient or family may have about the surgical experience. The nurse must verify that the consent, that the consent form is signed and he or she may serve as a witness to the signature, not the fact that the patient is informed.
Okay, because this is a normal practice. The surgeon should really go and get the signature, because they're already in there anyway. They walk in there, they explain to the patient the plan that they want to do surgery, blah, blah, blah. So they should bring that sheet there and then ask for the signature. The problem is they leave it with nurses most of the time anyway. And so nurses have to just obtain the signature and then sign as a witness. But remember that we were not there when the surgeon explained it. So all we're getting is that they signed it and you saw them sign the form. That's all we're verifying for. All right, so again, I'd like to emphasize we do not sign to the fact that the patient was informed. We have no idea whether or not that really occurred. And like I said, they can, if you suspect though that the patient had really no idea, it doesn't have to be factually correct. Meaning you just have reasonable suspicion to believe that the patient really doesn't know, okay, or there was no full consent, okay, meaning they had reservations, you know, they're not sure about this. So that means, did they receive informed consent? Because informed consent means they're aware of the basic facts for them to make a calculated decision. Because this is their life we're talking about. There are serious risks associated here. So anytime you don't have consent, simply call the surgeon. He'll just come back, explain it, and then everything's good. We're good to go. But again, the patient can change their mind. Okay, so whenever you have a problem, even in the holding room, you're about to sedate the patient. Okay, if you see, oh, we have no consent here, so we can't proceed. Consent is not just limited to signing, because what if the patient can't sign, or if the patient is blind, or if the patient is incapable of giving consent? So you have your exceptions here. Please read them carefully. This entire paragraph here, also on the next here, this talks about the blind patient. And there are also exceptions, okay, to the consent, meaning we can forego consent in the cases of emergencies. All right, so if the patient ends up in the hospital with no information whatsoever, the implication is, the assumption is that they're there to receive care, so they can't give consent, and the condition is life-threatening, right here. So consent is assumed. Okay, so consent is desired but not essential in those situations. If you have written or oral consent, so let's say the patient is incapable, right? A minor or with cognitive limitations, okay, developmental disabilities. If the guardian is not, or the legal guardian is not physically present, and you don't have a physical signature, you only have verbal consent, then you'll need 2 witnesses. Okay, so they're all written here. Here's the condition if it's blind. So again, you need 2 witnesses there. If the patient doesn't speak English, then there must be a translator. Now the question is, who is a qualified translator? Now your book says qualified translators are healthcare professionals or other types of employee. Does it say that you have to be a official translator?
No.
Here? No. So that the practice in city hospitals wherein it has to be the translator, that is a facility specific policy. All right, so legally, so here it clearly says health professionals or other types of hospital employee. If they're employed by the hospital, they are qualified translator. Again, don't go arguing when you go to the city hospital, because they have their facility specific policies. All right, this is just for NCLEX purposes. So if you see this question here, because this will be part of trends, or specifically under management of care category, NCLEX category, because this covers consent, advanced directives, delegation. Those are the non-med surg part of nursing, but you have to be qualified to deal with. So these are the topics covered under that. So you need to be aware of these details. All right. Mistakes happen even in today's world, although very rarely do we have wrong side surgeries, but it does happen. That's a big issue if it happens. It's embarrassing, and it's a big lawsuit, most especially. There is a law called Patient Self-Determination Act. This is the legal basis for advance directives, meaning when you sign a DNR, DNI, or in state of New York, we have medical order of medical order of life-sustaining treatment, yeah, MOLST. So that's unique to New York. We have these. The basis of that is this law, Patient Self-Determination Act. NPO. NPO means what?
Nothing but both.
All right, NPO is NPO, okay? Let's be clear about that. Nothing, absolutely nothing. The only thing they can eat is their own spit, because you can't really stop them from swallowing the spit. But absolutely no eating, drinking, no ice chips, nothing, no lollipops, nothing, okay? However, you saw under skip that patients who are on beta blockers, do we stop them if they're on NPO?
No.
No. Of course, can you give it by mouth though?
If you have an order for it with a small sip of water.
No.
Okay, well, we can't decide that. You still notify the physician if they're on, let's say, beta blockers or other drugs that cannot be stopped are steroids. Hormones, okay, let's say thyroid hormones, you can't stop these drugs. Seizure medications, you can't stop them. They have to be taken every day. So for drugs like this, your job is to notify the physician, and it's up to them to decide how to give it, whether to give it with sips of water or to ask pharmacy for a different preparation, like IV, for instance, if it's available for that drug. If it's not available in any other form, the doctor may be forced to say, okay, give with sips of water, okay? But there has to be a specific order, and he just can't say, oh, give those drugs. He has to specify, give metoprolol, give levothyroxine, give phenytoin, or whatever drug, okay? That has to be given with sips of water. It has to be specific, because NPO is NPO. So this is what I was talking about. So these drugs here cannot be stopped. It's not safe. Okay, but all others that are non-life-threatening, we can hold them for at least, that day. But these drugs definitely for seizures, hypertension, or heart disease, respiratory disease, or hormones, like I mentioned, they're stopping them can be life-threatening, or at least are detrimental for a patient undergoing surgery. Bowel prep are simply enemas, laxatives. These are done for bowel surgeries, okay, any abdominal surgery. Just be clear here when we say enema until clear. Clear doesn't have to mean like clear tap water, okay? It can never be that clear. Enema is considered clear if you don't see anything solid there, but it will be cloudy, okay? I mean, this is the colon we're talking about. It'll never be crystal clear, right? It's considered clear already if you don't see solid turds floating. Skin prep, we already discussed about the hair removal. Again, we only do electric clippers, no shaving. We don't need to do this because we're not prepping the patient for surgery. You need to tell them about tubes that will be coming out, because that will produce anxiety. Oh, how come I have this? And what is this? And also with vascular access, your job is to make sure the patient has IV access. The minimum size required for surgery is 20 or bigger. By 20 or bigger, we mean 20, 18, 16, 14. Okay, especially in case they need blood transfusion, so they need a 20. Here it is. So 18 would be best, but if we don't have it, then we're happy with a 20. This was already mentioned that you need to teach them about Dvt prevention, so post-op exercises that improves the legs, and don't forget the Incentive Spirometer for your respiratory care. So these are the breathing exercises post-op. Splinting when you do these breathing exercises, because especially if you have a abdominal incision, that might put strain on it as you do the deep breathing, because of course that increases pressure in the abdomen as the diaphragm pushes down. These are the leg exercises. Please read these on your own. Here's the incentive spirometry, breathing exercises we already discussed. Let's do incentive spirometry. Review it. From Fundamentals of Nursing, how is this used again? Any volunteers? Thank you for volunteering, Ashley. How do we use an incentive spirometer?
You teach the patient to put their mouth over the mouthpiece, both lips, and they have to breathe deeply up until they yes, inhale, up until it gets to the smiley face.
Okay. Do we do the inhaling fast, slow?
Slowly.
Okay, so the best way to remember this is they yawn into the incentive spirometer. Okay, a nice deep yawn. I mean, you know how to yawn, right?
Yes, sir.
Okay, yeah, I do it all the time. Here's coughing and splinting, again, to protect the incision. That's crucial, especially if they're coughing. These will increase the risk for blood clots. Don't worry about it now. We will discuss these in chapter 37. But you need to know the interventions though, because chapter 14 requires that you institute Dvt preventions, and they are enumerated here. As far as risk factors, we'll test that for exam 2. These right here, this will be exam 2, but the interventions, the Dvt prophylaxis activities are in exam 1. So this is what they look like. So when we say PCD or SCDs, they stand for sequential compression device or pneumatic compression devices. This is what they look like. So they fill with air alternatingly. So this leg first, that leg next, vice versa. The best, of course, is ambulation. But of course, the patient will have to lay back down in bed eventually. So while they're in bed, they have to be wearing these. When they're out of bed, you can take off the stockings, take these off. They don't need them because your leg muscles are contracting, squeezing them, promoting venous return. But anytime they get back in bed, the stockings get back on. All right, is that clear? Okay, the rest of these are psychosocial now. Of course, it's anxiety provoking. We only give anti-anxiety medications if necessary, but really the cause of the anxiety here is fear of the unknown. So the more you educate the patient, the better they understand, the better they anticipate what's going to happen. That decreases anxiety, relatively speaking anyway. So with any psychosocial problem, we always encourage expression of feelings. That's why it's here. Okay, let them talk. Listen to the patient's expressions. can just sit there, not even, you don't have to say anything. Just sit there, look attentively. Even if you're pretending, doesn't matter. We'll discuss the PACU, of course, in chapter 16, but this is in relation to your explanation though, because the patient or the family may expect to go straight to the post-op floor after surgery. Tell them that it's gonna take a while. Okay, they're gonna have to stay in PACU, or depending really on how they tolerated the surgery. If they, after 2 hours, they still don't meet criteria for discharge from the PACU, meaning vital signs aren't stable, there's considerable blood loss, they cannot return to the surgical floor. They'll have to go to the ICU. And I think we're done, because these are just the these are some housekeeping stuff about possessions. I don't know really why patients bring jewelry when they go to the hospital, or money. What are you gonna do? It's not like you're paying cash. Okay, you're billed for the hospitalization. So these are just some things patients should have known anyway. However, dentures are important. Although we have less and less patients having dentures now, because implants are the popular thing now. But in case you still have patients with full dentures, then these things are expensive. You don't want to be responsible for losing them, so you have to know how to care for them. Put them in a safe place. Make sure you don't lose them. Jewelry wise, it's usually the wedding band, because people don't take them off, so they have to be off, because they are, even if they're not technically metal, I mean they're gold, but it may be a risk during cautery, because we use electric cautery when we stop bleeding in the OR, meaning we burn small capillaries and arteries. So it may cause electrocution if they have anything metal on them. But you never know, the jewelry may not be real gold, could be metal. Some drugs, these will be administered pre and post-op, especially the sedatives. And we'll take care of the overdose in chapter 16, which will be next week. This is now your handoff. So we started with the pre-op checklist. Now we're getting ready to transfer the patient to the OR now. So somebody will call the morning of surgery asking for you, the pre-op nurse, telling you that we're coming for your patient. Once they call, that's your cue to take vital signs, because you need to send off the patient. This is your handoff. So you need fresh vital signs in there. So you put your vital signs in the S-bar. Usually we have an S-bar form. We don't have papers technically anymore, because there's no physical chart. Everything's in the EHR. So there's really no paper to speak of. Okay, the patient, maybe the consent, but I don't know if the city is going into electronic signatures now. But if anything, the only paper there is the signed consent. Okay, they need to see that. But otherwise, there's no paper or chart really to speak of. And that's it for 14. Any questions? I'll give you a break, and then we'll end the day with your quiz. After you finish the quiz, you are free to go. Any question?
Just a quick question. How long do we have for the quiz?
Everybody has 30 minutes, except for a few who have time and a half.
Professor,
Yes.
not that I plan on it, but if someone didn't pass the dosage exam, would it still be like the other semesters where you get like 3 options to try to redeem yourself?
Absolutely. That hasn't changed, will not change. So you still have 3 attempts.
All right, thank you.
Professor, how many questions does the math?
Oh, it's still 10. It's on Juno, so it's fill in the blanks. You can go back, okay? So Juno, you have arrow, right? You have left or right arrows. Just a heads up, only enter the number. Don't put mLs per hour, don't put drops per minute, don't put tablets, just the number. Okay?
Professor,
number.
is it Juno?
Juno. It's on Jupiter.
Jupiter. Okay. I was like, what is Juno?
That's on Jupiter, right?
All right, thank you.
Thank you.
What about decimal points?
Oh yeah, you'll
Okay,
be
cool.
instructed on the question. Will tell you whether or not to round it to the 10th, a whole number. It's specifically in the question.
Okay.
Okay.
But again, only numbers, okay? No units involved here.
Okay.
Thank you.
Professor, I have 2 quick questions.
Yes, boss.
One of them are we going to get a separate link for the Zoom invite for that?
No, use the same what is this thing? Zoom. Okay, so the same invite. All you do is just turn on your cameras this time.
Okay, and for those of us that have extended time, will we get a separate link?
No, you'll be in the same. I'll mute everybody. You're on your own anyway. So again, for everybody who's done, no need to say goodbye. All right, just exit.
So we don't need 2 devices, Professor?
Yes, that way I can see you. If you have a tablet, it's okay that you have your camera on the tablet facing you. That's fine.
Okay.
Yeah, it's really for those who have devices that have no camera, then you'll need a second device. Okay, at least for this one, this is only the dosage calculation. It'll be
okay, so I can use like the laptop I'm on right now. I can use I can just turn on the video and that's it.
Yes, that will do.
Oh, okay.
Professor, one more question. Will we find out our grades immediately or?
I set it up like that, but I don't know if it worked for the guys that took it yesterday. It didn't. I don't know why. Yeah, if not, it'll be later tonight. Okay, I'll ask my youngest daughter to release to manually grade it.
Okay.
She knew what to do. She did it yesterday.
Copy.
I hope she likes the number 100.
Well, she's just clicking 2 buttons. She's not typing anything.
Okay.
Yeah. Any questions? Okay, so we can start actually at you still want to start at 10:20 or earlier?
Can we start earlier?
Earlier. 5 after?
Sure.
Okay.
Okay.
What's that, Professor? I'm sorry.
5 after 10?
Thank you.
Actually, we could have gone on. Well, you need a break. Okay, so 5 after, come back for so just go get your cameras for those who need a second device, calculators, scrap paper. Alrighty, just be careful the time. Okay, there's a timer on your test. Just be aware of the time. All right, I'll see you guys in 15 minutes.
Thank
you.
Thank you.